You are watching PEMU-TV, Buri Hamwe.
Atwiine, the Permanent Secretary, Minister of Health. We thank God that we have come to the end of the year. We have had many challenges in the country. One of them is excess rain because of climate change. We are seeing the impact of climate change in reality, and we have had the surge in malaria. We have had more deaths due to road traffic accidents. The roads have collapsed and bridges and making it even transportation of our medical supplies to reach the facilities because of excess rains and all those, so many other things. But we wanted to remind you of 4 things. The first one is that Christmas is the time for celebration, but it is not a time for being irresponsible with our lives. We want to remind you also that out there are many dangers. One of them is reckless driving, especially those drink and drive. We have seen more numbers of accidents increase the time of festivities, and we request that you take precaution as you are driving, as you are partying, to be responsible because your life matters. The third one is that we have seen also reckless lifestyle at the time of festivities, a lot of eating, NCDs are on the rise. NCDs mean non-communicable diseases. We see a lot of eating meat, a lot of just binge kind of eating. We want to remind you that you are what you eat, or what you eat, you become. We have seen a lot of NCDs arising out of dietary behavior, lifestyle behavior, drinking, eating a lot of things that make our bodies end up becoming what they are, especially when we get non-communicable diseases. So we want to remind the population that we still have, and we are still seeing, a big number of cases of non-communicable diseases on the increase. We want to caution, we want to remind you that we need to be vigilant about our lives. We need to be healthy, we need to eat healthy, we need to observe our health behavior. If really people make a resolution to take care of your health, to live a healthy life. Lastly, I just want also to remind you that our children, our girls who are in holidays, the vacists, all those holiday makers, please take care of yourselves. First, HIV is still there. Do not just live a reckless life. Do not live a life that will expose you to diseases like HIV, like other STDs. We want to remind you that also teenage pregnancy will ruin your future. Move away from circumstances that will put you in a circumstance or the conditions that will lead you to getting in areas that you are disposed to unprotected sex, and that will lead to pregnancy. We still want young people to take care of yourselves. Avoid groups that will lead you to taking drugs. Avoid alcohol. Avoid drink and driving. Avoid the community that will lead you to sexual contact that will lead you to many risks that will also destroy your future. So we really want to remind you that also, because of excess rains and a lot of flooding, a lot of waterlogging all over the place, we want you to take care of yourselves against malaria. Sleep under mosquito nets. Make sure you don't stay out very late, because still mosquitoes are there and you will expose yourself. Malaria kills, and malaria is still the leading cause of mortality in our country, especially the children and the pregnant women. Thank you very much. It was earlier, they were building small, tiny health centers at parish level. But we realized, and I think even the president emphasized this to us, that we don't need to spread so much, so thin, putting up small, tiny little health centers, which we call health center twos, but instead we focus on health center threes per sub-county. Because a sub-county is really a unit where someone can come wherever they are, even maybe with the exception of 3 conditions. The exception of the islands, because the islands, even if it is not a sub-county per se, but because it is in isolated areas, for the people to increase the access, those ones were supposed to upgrade, regardless of the unit, I mean the volume of the population. The other condition was in sub-counties that are very big, that people have to walk over 10 kilometers or maybe 20 kilometers to get to health center threes. Those were supposed to have exceptional to have another health center 3. Another one was in mountainous areas. If the access is limiting the people to reach the health care, regardless of whether it is a sub-county, but if it is very difficult, we're supposed to put the health center 3s. But the principle and the policy is every sub-county is supposed to have a health center 3. And this health center 3, the new structure right now, we have increased the number of staff to about 43, the number that would match health center 4. And these health center 3s are supposed to be managed. Right now they are being managed by clinic officers and nurses. They are not doctors at health center 3. But in the new structure, we're proposing that if we're given more resources, we also put the doctors at the sub-county, so that people don't have to move long distances to access the services of a doctor. So that's how the president guided and told us that we first halt, and we should not construct any more health center 2s. But we get those health center 2s in those sub-counties, especially that are strategically located in the middle of those sub-counties. We upgrade them to health center 3s. As I talk, I think we have upgraded more than 350 health centers, health center 3s. Much, actually I think 390 something. So we continue to do that. The only challenge has been that we have continued to get more sub-counties created, and therefore we find that we are not able to match the rate at which the sub-counties that are created. If we had stayed on the old sub-counties that we had, by now would be more or less done for all the sub-counties in the countries will be having health center 3s. So that's where we are now. On the issue of referral, We have our referral policy. We have defined specific services per level of facility. At Health Center 2, we have clearly stated the services that are supposed to be given, because Health Center 2s are really lowest. Actually, VHT, the VHT is what someone would call Health Center 1. The VHT in the village, they just identify where the condition is, and they encourage either mothers or children. We provide the VHTs with some basic medicine so that when children, get sick, a woman in the night has a child, the nearest you can go to is a VHT. So at least they are given some paracetamol, they are given some thermometer to measure the temperature, they are taught those basic things, so that if there is anyone, especially the children, the intervention is faster. So then Health Center 2s, of course, we vaccinate, we treat the basic, flu, cough, malaria. Also, women go there for antenatal services. In some Health Center 2s, actually, like Western Nile, they are also delivering women. Although they are, because there are so many women who are being delivered there, they have very high fertility rates. So even Health Center 2s are functional. So Health Center 3s, they also do the basic services, but in addition, they are able to do antenatal vaccinations, but at the same time, they are able to deliver, because we put midwives there, we put clinic officers, so they are able to handle relatively bigger conditions or more complicated conditions more than Health Center 2s. Now at Health Center 4s, where we expect, right now in the new structure, we call it community hospital. We have increased the staff to above 150, and this ideally is supposed to be like a general hospital kind of, but now we call them community hospitals in our new structure. Now this community hospital or Health Center 4s is supposed to be headed by a doctor. They are supposed to be admitting. Health Center 3s, they admit sometimes when they are hard up, but ideally all admissions, apart from the deliveries of the mothers, all other services like severe conditions that require admission are supposed to be handled at Health Center 4. We operate, they are supposed to have a theater, they are supposed to operate mothers who have failed to deliver normally, they are supposed to operate for other conditions. So because there is a doctor, so the services are more, they are able even to treat more complicated conditions that the clinic officer cannot treat. Now, at General Hospital, it is more or less now that it is bigger than Health Center 4 in scope. But if you have the staff that is required at Health Center 4, it's more or less like a general hospital, because also general hospital, they handle all the general conditions. The more complicated and specialized services go to regional referral. And the regional referral, so if there's a more complicated, like someone has cancer, someone has heart disease, someone has complicated uncontrollable diabetes, someone has preeclampsia and cannot be managed in the general hospital, they are referred to the regional referral, because we have specialized services there. Then upward from referral to national referrals. However, we still have challenges. We continue to teach our people, because I have had people who go to Health Center 3 and they expect, for example, to be treated with a heart condition, or someone has complicated diabetes where they need the insulin, but at Health Center 3, they don't have that personnel to manage that complicated diabetes. So you find that people don't know what service is where. And when they go to Health Center 3 and they are told that this particular medicine is not there, they think, eyo tewali ddagala. So we continue to educate our people to go to the level where they are supposed to meet. If you have a complicated condition, even in Mulago, the medicines they stock there is for higher conditions. Kidney disease, heart failure, severe liver disease, brain conditions, neurological conditions, So now that's where the medicines of those kind of conditions are stored. And even the specialists for those conditions are in those hospitals. So when you go to lower units, health center for just a general doctor who has just finished, campus and has been posted there, they may not manage the conditions that the specialist is able to handle. So, but it is still a challenge, because you find even malaria, someone going to Mulago, you find someone who hurt his leg or just minor trauma is going to Mulago to be handled. So we continue to educate people. That's why we have created now specialized entities. If you see in Kampala now, we have designated hospitals particularly to take care of specialized. For example, if you go to Kawempe, you'll find that they are able to handle only women who come, who want to deliver, but also who have complications for deliveries, those who have neonatals that are sick. So it is handling women and children. When you go to women's hospital, it is also handling all the referrals related to women and deliveries, and also neonates. When you go to Chirudu, you find that they are handling surgical cases and medical cases. When you go to Naguru, we have designated it as a trauma hospital. Although we have not yet put in place all the required equipment, we want to remodel it to fit the purpose of trauma hospital. So that we create that specialized entities. In Mulago, when you go to, you will see Heart Institute, they are concentrating on heart and related diseases. When you go to Cancer Institute, they are handling all the cancers, so that we are able to create that specialized kind of services. In Lower Mulago, we are now working on ensuring that we start kidney transplant and all those highly super specialized services. So that's how it is. But still, we continue to educate our people to learn that they don't have to go to Mulago if they just have malaria or simple diseases, because that hospital is for those other specialist conditions. But when we cannot turn down people, we continue to accept, but we continue to educate them. But we are going to get to the point, if we have fully functional facilities and more facilities in Kampala, we will not be able to take people to Mulago. We'll be able to encourage them to go to those other units.
Briefly, you talked about the VHTs.
Volunteers. We have over 100,000 in the country, actually over 150,000. They are more than our health workers in the country. Now, it was not possible to put them on a salary because of the budgetary constraint. But we are looking at also other alternatives. Like at parish, if we introduce at least 2, instead of looking at village level. And we are piloting to see how this can work. If this can work, then we'll come back to, because we had proposed and we came up with a strategy, which we presented, although still at that time the fear was, where do we get all this money to pay? And so somehow it was halted. But we are glad that along the way, PDM came in handy, because PDM is actually a replica of what in health for us we had come up earlier, many years, like 6 years ago. So we wanted really to focus at household level to strengthen services, primary health care, community interventions, teach people how, issues of hygiene, immunization, antenatal, cleanliness, all those conditions, why mothers should go for antenatal, why all the children should, at household level. We measure your blood pressures. Many people are staying at home. They have high blood pressure. They don't know. By the time they come when they have kidney failure. They didn't know. Some come with diabetes when they are already go to complications. And those complications are very, very difficult to treat. So we want really to prevent at household level. And if we do that, we shall see less people coming to the hospital. We shall see less pressure on tewali dagala, government etuyambe, that kind of thing. So we want really to focus at household. But that household level, you require a cadre that you will train, who is trainable. VHTs, some VHTs are just volunteers, but they have not studied. So you will not expect them to do a little more complicated things. Some have studied, and actually, like if we are going to implement CHOOSE, we want to give opportunity to those VHTs who have been in the community and they are educated and because we've been training VHTs, equipping them, supporting them in all these activities that we are doing together. So somehow they have some knowledge, but some you cannot demand so much because really someone is volunteering. So if we introduce this other cadre at parish to fit into the parish development on social services, Pillar 4, that the CHU will be able to work with our health assistants in the sub-county and parish to collect information. We have developed information system which you put on the phone, and you collect data at household. You collect data on sanitation, you collect data on family plan, you collect data on malaria, collect data on TB, on pressure, on non-communicable diseases. Now, on nutrition, nutrition, it is either under or over nutrition. So all that information. Now, that information is brought forward through to the health assistant, who is the head, our work at parish. Now, that person should be able to present the findings at parish in PDM framework to present the social service at the parish. But that health assistant cannot work alone. That's why we are still working with the VHTs, provide us with information. Some VHTs, we've given them phones, we've given them other toolkits to help them collect that. So we think that this is something that will not, at the moment, we are not able to fund, but we know that VHTs remain, they are very, very important cadre, but we are not able to pay them. But with time, maybe when money is available, maybe it will be possible. But for now, it is not possible.
Thank you very much.
Webale kuleba PMTV buli hamwe.